who lives and who dies is always determined, or too often determined, by their social station, by racism, by histories of colonial rule, by gender inequality, and that this can be countered and has been and will be when we come together to build a progressive social justice movement that reaches far from wherever we may live.
Aloha, Kalamaoka'aina, Kilsun Niheu Keia. My name is Dr. Kalamaoka'aina Niheu, and it's my great honor to welcome all of our guests from here in Kapai'aina as well as across the world, and to especially welcome our wonderful guest, Dr. Paul Farmer. And in the tradition of our people, the Kanaka Maoli of Hawaii, I would like to do an oli to help ground us, to help center us, and to help remind ourselves to bring in the ike of our people and our ancestors so that we can learn and be open to join together in the hopes that conversations such as these will allow us to be bigger, better, and stronger. E ho mai kai ke mai luna mai e. O na hamea huna no iau. O na mele. E ho mai. E ho mai. E ho mai. E ho mai kai ke mai luna mai e. O na mea huna no iau. O na mele. E ho mai. E ho mai. E ho mai. E ho mai kai ke mai luna mai e. O na mea huna no iau. O na mele. E ho mai. E ho mai. E ho mai.
Thank you. My name is Seiji Yamada. Thank you, Kalamaoka'aina, for the oli. We in Hawaii should acknowledge that we are on Kapai'aina, land, ocean, and air that originally belonged to the Kanaka Maoli people. For anybody joining us today, I think that Paul Farmer needs no introduction. Instead of listing all his titles and accomplishments, I'd like to pose a question. Why does Paul Farmer visit us in Hawaii? I suggest that the answer is that he wants to help us build a social movement for health here in Hawaii and the Pacific. Dr. Farmer last visited us in 2007. My friend Gregory Maskarinic and I were hoping that his visit then would have kicked off a social movement for health here. While there have been some positive developments, and Dr. Kalamaoka'aina Niheu will tell us about some of those, we need to do more. Dr. Farmer is joining us tonight to give us another chance. He wants us to join him in the practice of social medicine. If you read AIDS and Accusation, you'll find chapters about the colonial history of Haiti. If you read Fevers, Feuds, and Diamonds, you will find chapters about West African colonial history. His message is that you need to understand the large-scale social and historical forces in order to understand why the poor are so sick. Moreover, Dr. Farmer addresses the deep inequalities that lead to medical deserts by bringing medicine and medical education to where there is none. By demonstrating that it can be done, he helps us overcome the prevailing pessimistic view that little can be done for the poor. I ask those of you joining us today to ask yourselves how you can apply Dr. Farmer's message to our work here in Hawaii and the Pacific.
Thank you, Seiji. as you can imagine, I feel first of all, very grateful to be invited back, and a little intimidated by the introduction, and also very grateful for Kalama's centering of us and her work, of course, in general, especially over the last couple of years fighting COVID. I wish I were with you. I'm in right near Volcano National Park, but Volcano National Park in Rwanda, and this is it's a picture a photograph that centers me. The sun isn't up yet, but I can see already this hospital, which is a public hospital built in a region of Rwanda that had no hospital. And it was the last district of 30 to have one. And I even hope you can see get a feel for the region, but also the love that we attempted to put into this hospital in building it for the people of an underserved region in collaboration with the health authorities here. And I want to talk not about health policy in Hawaii, because I would be out of my depth and we have other experts here, but about ways of pushing forward pragmatic solidarity focused on what we hear again and again, and this is true of nurses, physicians, any frontline worker, social worker, anyone who attends carefully to what is said or pays reverent attention to it. The material privations, the history of colonial rule and its legacy on this continent have meant very practically a lack of the staff, the stuff, the space, the systems, and the support that you need to attend to illness or prevent it. And I will go back again, as Seiji has asked me, to policy questions and how social justice activism might help move forward towards a better tomorrow. Next slide, please. And then I also want to thank my colleague Ishan, who got up early. I consider myself still not to be a very informed person on way too many topics, but my first teacher in many ways outside of a university was in the year between college and medical school when I ended up in a squatter settlement in rural Haiti. This is, I know this isn't 1983 because there were no cement buildings there. And I didn't even know that there were squatter settlements in rural areas. It was something that as a 23-year-old I associated with urban areas. But if you look at this picture, and some of you have been to Central Haiti, it looks very different now, this area, you'll see that in the background is a body of water. And that is not a natural lake, but a hydroelectric dam, a reservoir that flooded a valley of the most fertile valley in the region, and sent not only water, but later electricity off to the capital city. And in these hills were I found out my teachers. Some of them have passed away, but they're still my teachers and my friends, as are their children and now grandchildren. And this is where I learned a lot of hard lessons and saw very few victories for a long time, and started to learn why, and the question asked in the title is who lives and who dies. And I think that these are not often mysteries. Certainly they didn't seem like mysteries to the people who lived here and told me in clear, no uncertain terms, how they had been moved from what they called decent poverty into destitution. And with destitution, and without it, of course, comes sickness, disease, illness, injury. Next slide, please. And I want to also ask for forgiveness for mixing up this with a more medical lecture, but this is a very modest example. We began seeing HIV which in rural Haiti in the 1980s. Seiji mentioned a book I wrote, AIDS and Accusation, which is about how racism plays a role in transnational spread of pathogens, about other things as well, as you mentioned, colonial history. But by the time we started seeing patients usually coming back from the capital city to these villages, they were often coming home to die. And we had seen this before with other illnesses. Again, that didn't mean that they didn't seek care elsewhere outside of what we would call a clinical desert. They had, and whether it was breast cancer or tuberculosis, people were going on these long and often desperate quests for care. And so we built there, along with many partners, a small hospital, first a clinic, and started seeing a pattern that would later be well documented around the world. First of all, these are just 200 patients who showed up. And when you open the doors of a clinic and remove user fees and other impediments of neoliberal thinking, you'll see every kind of pathology. And I'll turn a little bit later to cancer here in Rwanda and to the problem we're all facing now, which is COVID. But here we noticed, again, this was a pattern to be repeated and was already going on elsewhere in the world, including American cities and across this continent where I am now, that most of the patients who presented with HIV disease, with documented HIV infections, presented with pulmonary TB, which was then the leading infectious cause of deaths among young adults in the world, until it was surpassed a few years later by HIV, and it has now reclaimed that position once again. So we asked ourselves in this era, and if I may add a personal note, in 1993 to 1995, I was myself, as was Dr. Yamada, in training, and I was training in infectious disease with an interest in tuberculosis for the reasons that I just mentioned, the burden of disease, the fact that there had been curative therapy for decades, but the problem was distribution and equity and even reparative actions to make these therapies available. So we asked ourselves, do we know how to take care of tuberculosis? And thought the answer was yes. We had introduced a program that focused on the needs of patients, not on the needs of staff, a growing medical and nursing staff. And we started talking in terms of who were the staff we needed most. Were they infectious disease doctors, as I was striving to be, or were community health workers more important? What was the stuff? Was it only drugs like isoniazid, rivampin, ethambutol, and pyrazinamide, or did that include food for the food insecure, which proved to be the majority of our patients? What was the space? Did we want people to be away from their families for long times in an institutional setting, or could we do better with community-based care? What were the systems? How did we look for hidden fees and costs that prevented patients from adhering to therapy and reaching cure? And then finally, and perhaps most importantly, and we focused on support to the patient. And this, again, sometimes meant helping them get from one village to another. I do believe we introduced the term donkey rental fee into the medical literature during this time. And we asked ourselves right at the end of this period, 1995, what is our equity plan as new therapies are developed for HIV? And I want to tell that story a little bit. Of course, any images from patients are used with their approval and usually their blessing. Next slide, please. So what we began to see was people returning again, usually from somewhere else in the country, with both HIV and tuberculosis. And this is a young man that I met in a public clinic, because we were trying to ask ourselves, and I've written a little bit about this with Seiji and others, what is the function of a public hospital? Is it not as a safety net? Is it not the way that we could ensure access to health for all, which at the time seemed an empty slogan to so many? And this young man had disseminated tuberculosis, HIV, advanced HIV, and it was at the time, of course, that there was a great deal of skepticism expressed on behalf of other people, most of them Black and brown people. That is, and you remember, and I'll bring this up, that it's not possible to treat AIDS in resource-poor settings. You don't have the doctors, you don't have the staff-based systems necessary to do so. So who lives and who dies depends not only on epidemiology, on whether or not there's prevalent tuberculosis when HIV hits, but it depends all too much on the decisions made by policymakers who then do not themselves face these kind of problems. The next slide, please. So by then, we had begun collecting, with the help of AIDS activists, medications that would allow us to take care of people like, please go back one, like T. Joseph, which is what he asked us to call him. And it's not as if it were some miracle. It was merely, it's not as if there's a different physiology for rural Haitians than, the men and women I was seeing in Boston at a time when HIV was also the leading infectious killer of young adults in the United States. But rather having not only a system of delivery of care, but a commitment to reversing the inequalities that made it seem so unlikely, again, especially to certain policymakers, so unlikely that this would ever reach rural Haiti, to say nothing of the continent that was clearly the most effective, and that's this one. Next slide. And I won't spend a lot of time on this slide. This is also, again, T. Joseph now at home, but this was not a small project at the time. And my Haitian colleagues, who term community health workers accompagnateurs, people who accompany, are the ones, of course, who rolled this project out through public hospitals, which had been fallen into, were basically not functional across this part of Haiti. And this is not a small part of Haiti. It goes from the Dominican border all the way to the coast on the west. And there are millions of people who live there. And so we began using the same approach that we had with tuberculosis, which we knew worked, which was to focus on community health workers, on making the stuff available, in this case, antiretroviral therapy, and to providing the support to the families, but especially the patients and even staff, with results that we began to feel not only on the level of the population eventually seeing not a rapid, but a significant decline in the prevalence of HIV, but also a very marked improvement of morale among our staff and co-workers, who were all Haitian, of course. And that included not only the community health workers who shared the social conditions of the patients, but the nurses, the physicians, the managers. And again, I use this jargon, strengthen health systems, and I know this is a relevant question in Hawaii as well. Why have we divested so much from our public health delivery systems? And also, why have we ever tried, and have we ever succeeded at continuing disease control to the exclusion of caring for patients? And this is a logic which lives on to this day, that's rooted very strongly in colonial medicine, which again hit Haiti much earlier. During much of colonial medicine, there was none at all. But surprisingly, it gathered force in the late 19th century. And as I was able to discuss in my remarks yesterday, this was the time of significant scientific advancement in Europe and North America and some other parts of Asia. But there was really never any plan to share this bounty with colonial subjects, the majority of whom lived in India worldwide, but all of Africa became colonized not centuries ago, but really at the end of the 19th century. And colonial medicine, I won't go over what I did yesterday, is a control over care strategy that continues to bedevil us today. And I'd like to show how that played out or is still playing out today. Next slide. So this is another way of putting it. Interestingly enough, this is a graph that was made by a Gapminder, but as you can see, it bears the imprimatur of the UN, one of the UN affiliates, UNAIDS. And at the time that this great divergence was occurring, there were fairly loud recommendations from self-described authorities that it was not possible to treat AIDS in Africa. And before I go to the next, ART of course means antiretroviral therapy. And before I go to the next slide, I'd just like to say, think about the various health problems that you're facing there. It may be a new COVID vaccine. It may be a new chemotherapeutic agent. It may be a kidney transplant. Indeed, I'm on service here at a hospital where all of these questions have come up just in the last 40 days. They come up every day. So when you introduce a new and beneficial technology, whether that be a preventive or a diagnostic or a therapeutic, if you don't have an equity plan, why would we not see this divergence? So even with our weak and weakening health system in the United States, the impact of ART on mortality among Americans or people living in what are called the boundaries of the United States, mortality plummeted as it was getting ever worse in other parts of the world. And of course, I will address in-country variations as well, what many used to call the third world at home, populations within affluent countries who were also being denied the fruits of modern medicine. Next slide, please. So what were some of the things that were said? And I've taken the names of the people who had said these things away because this was really conventional wisdom and repeated again and again, that the lack of staff space systems was not a challenge to marshal resources to address these problems, but rather a reason for inaction. You heard stories about, well, Africans have a different sense of time. They don't have watches. By the way, this infuriated my Haitian colleagues and many of our patients who had become our friends and coworkers as well. The list of excuses for inaction should be familiar to you. But fortunately, next slide, there was a brisk counter response. And here, I just want to imagine what things would be like here and elsewhere, if not for courageous AIDS activists, and particularly in the United States, but also in Haiti and in Africa. This picture was taken in Durban, South Africa. I was at that protest myself, and some remarkable things happened. To have the required staff, space systems, and support, you need resources. And if you have any sense of history, these could be called mitigating resources, or they could be thought of as long overdue reparations. But without these resources, we'd be living in a different world today. In the 3 districts where Partners in Health works with the Rwandan government, the Ministry of Health, we haven't seen, I believe, in 3 years, any cases of mother-to-child transmission of HIV. And I remember when I was a resident, I assumed at the Boston teaching hospitals, I assumed that HIV would be a major killer of American children, and it hasn't because of this technology. But healthcare delivery in an equitable manner still remains far too elusive. But this is a story of how activism helped to change policy. Next slide, please. And that's how we ended up here. Again, this was just to describe it in more Seiji Yamada-esque terms. This was a community-based effort to not just control AIDS with a control over care paradigm, but to take care of people with HIV, and without the usual curse of user fees in settings with no health insurance. At one point, when we looked a few years ago after the earthquake in Haiti, which has probably 11 million population, about 60,000 families could count on reliable health insurance, and we didn't know any of them. And even though sometimes they do come to the hospitals that we've built because they're good hospitals in rural areas, we don't even know how to charge them fees. So the reasons that this was attractive to the Rwandan authorities after the genocide against the Tutsis was because they have and still have a largely rural population. And as happens with war, genocide, these are potent multipliers of epidemic disease, and HIV was no exception. And so we were lucky enough to come to Rwanda in 2004. It says 2005, which is when we were sent to first one, then two, and then 3 of the 4 districts without any district hospital at all. So our mission was never, what they call in public health circles a vertical mission to control or treat HIV, but to introduce comprehensive, publicly supported healthcare services, including prevention, but focusing on the ill and injured in 3 of the 4 districts of Rwanda with no remaining, with no hospitals at all. And when I say district, I just want the people listening in Hawaii to know that sometimes these were 300,000-400,000 people strong. These were large populations without access to even primary care. So we used the same model of accompaniment, and our Haitian colleagues, when I say we, our Haitian colleagues helped to lead this effort. And it was, of course, in very rural areas. But one thing we saw in Rwanda that we had not seen in many of the other places where we worked was a government that made very clear commitments to health equity in explicit terms. That when this rollout, and again, a rollout not just of HIV care, but of primary healthcare service, when it began, it would be focused on rural people, on the poor. We used a different kind of language, a preferential option for the poor. They didn't use that term. They talked about the bottom quintile. They talked about widows and genocide survivors. So the plan that was developed by the Rwandans, including one of the person who became my closest friend here, the pediatrician Agnes Benegwahu, who helped to write that plan. In this plan, the staff self-space systems and social supports were baked right in, as the Americans say. Next slide, please. So we were, again, sent to rebuild facilities. This is not rocket science. Who would go to an abandoned hospital without physicians, without reliable electricity, water, without service? And the answer all over the world is very few. So rebuilding that, that hospital was not a difficult task. But we also saw the same kind of Lazarus effect in Rwanda that we saw in Haiti. Next slide. For example, many of our colleagues in Rwanda were skeptical that we would see those kind of transformations. But my Haitian colleagues and others from Partners in Health were not skeptical. And it didn't take long. Again, all you have to do is open the doors, meaning fling them wide open so anyone would come in. And people in desperate circumstances, in this case, this man's name is John, with both tuberculosis and HIV yet again. And the same, and the impact on the staff was which again, there was no staff there. So recruiting nurses and physicians to rural areas was very difficult at the time. But when they began seeing results like the community health workers themselves were already living there, and many of them were recruited among the ranks of people living with HIV or having survived tuberculosis or some other illness. So they were already there. But the more this happened, the stronger the program became. And let me just give an example that would be the next slide, the envy, even of a clinical trial. With accompaniment and with strong support from the Ministry of Health and National AIDS Program, we saw results among even the sickest. And these are the first 1,000 adults. The numbers are even better among children. We did not lose people to follow up because there were community health workers. And we did not see many defaulters, which is probably a bad term. So we saw survival. And the question for the Rwandans ever, it seemed to me, was, but what do we do on a national scale? And so although the models have varied from district to district, the commitment to rolling out these services, linking them to basic primary care, in other words, health system strengthening, and making this a public good for public health rather than a neoliberal approach to making it a commodity to be sold, did get rolled out, and quite rapidly. Next slide. So this is at a time when the World Health Organization was defining universal access to HIV care. This is what happened in Rwanda, which is one of the poorer countries. It's less poor now than it was 10 years ago, significantly less poor. But Rwanda met those criteria before any other country did. And again, back to the question of who lives or dies, this is not some great mystery. Next slide. It was an equity-focused approach. In fact, when linked to health system strengthening, the Rwandans could reasonably claim, whether looking at under 5 mortality, whether looking at HIV, malaria, TB mortality, whether even looking at maternal mortality, to have seen the steepest declines in mortality ever documented at any time and any place in human history. And again, I would like to argue that baking in the equity component is a big part of this, and focusing on the neediest first. Next slide. So just to as a segue to talking a little bit about COVID and the challenges right now, as I said, when you open the doors in a sincere manner of a clinical facility in a clinical desert, meaning without the staff subspace systems, you're going to see a lot of patients with cancer. The same sort of pessimism that I discussed yesterday was expressed abundantly among policymakers, officials who should have known better and whose job it was to think, how can we deal with non-communicable diseases? Many cancers are communicable, of course, but how can we deal with what is now a very clearly a ranking problem as deaths due to malaria, tuberculosis, and HIV decline? So we were lucky to be in Rwanda because instead of being the house of no, and the no's are always the same. It's not cost effective, it's not feasible, it's not sustainable, it's not even prudent, it's foolish, you can't treat cancer in rural Haiti. All of these, I've heard all of these things from health authorities, usually not African health authorities, but they are very reminiscent, of course, of objections to HIV treatment. So this is what the house of no looks like. People showing up, and we even started calling this CIOS, carried in on stretchers. But what, of course, Rwanda really needed was cancer care. And at the time, there were no oncologists. There's still only one, at least in this part of Rwanda. But there were nurses, doctors, and community health workers, and leaders. By the way, Agnes had by then, because of her success with AIDS, become the Minister of Health of Rwanda, and where she probably is the longest serving Minister of Health, 5 years. So with the support, once again, of the Ministry of Health, we decided to open a cancer center of excellence up here on this mountain, which when we arrived had no hospital, but also no doctor, no electricity, and no running water. And that's where we built the hospital you saw on the first slide, and that's where we built the cancer center. This is one of my closest friends, Dr. Cyprien, who leads it, and opened this not too long after opening the hospital. And I don't have to tell you what happened, you can guess. A flood of patients with advanced malignancies, but also that same flood of disapproval and pessimism on behalf of other people, again, usually Black and brown people. We also learned surprising things. I had been told that cervical cancer would be the ranking malignant killer of women across this part of Africa. It isn't. It was breast cancer, which is the number one on our list to this day. Yesterday, Dr. Cyprien and I were teaching, and one of a breast cancer survivor who's now 10 years out taught with us, and she received her care as well. As far as I know, this is the only cancer center anywhere in rural Africa. And again, the reason it's so busy is we removed the curse of user fees, helped with transportation, et cetera. Next slide. And now, just to close, and this is all too familiar, and our next speaker knows a lot more about it than I do because she's put a lot of heart into her COVID work over the last 2 years. There was no doubt from the beginning of the pandemic, when you heard in the newspapers that it would be a great leveler, we all knew that was false. And the numbers, although deeply disappointing, are not surprising to anyone. The risk, not only of exposure, but the risk of not being able to protect your family members and from COVID were obvious from the outset. I want to turn to the next slide, however, and open this up on a more optimistic note. We knew already that in Africa, we would face vaccine apartheid because 99% of all vaccines used on this continent are imported. And it seemed very likely to us, given past experiences, that there would not be a concerted effort to amp up vaccine manufacturing on this continent. But again, I'm very grateful to be working here because the Rwandans had a very different idea of what should be done. Next slide. First of all, as someone who has worked in prisons, and here, when we came here 20 years ago, 70% of detainees were there on genocide-related charges. We also found that the government had not only no objection to us working to deliver medical services there, neither did our colleagues, many of them victims. There was a lot of support for work within the prisons. There was also a penal reform movement going on that's here called Gachacha, which I'm embarrassed to tell you, I was skeptical that it would work. I was wrong again. There were no retaliatory deaths as prisoners were moved out of incarceration and into a collective form of acknowledgement and I won't call it the equivalent of outpatient care, but it's impossible to manage epidemics inside prisons if they're this crowded. And the one that we worked in had 11,000 detainees. And I spoke yesterday already about experience in Russian prisons. And they were online because they were considered vulnerable populations to receive COVID vaccines. When we were arguing still about community health workers elsewhere, the community health workers we work with, and we work with thousands, there are probably 100,000 community health workers in Rwanda, 12 million population. They were on the list. And I'll just say, having been on service here over the last month, I've seen many, many sick patients, in fact, only sick patients, but all of them have received COVID vaccines, and many of them boosters, especially if they have immunosuppression. So Rwanda, which is still, as I said, is one of the poorer nations in the world, as far as I know, leads the list in terms of rates of coverage. And they also said that they would find a way to try and make vaccine and use these new technologies here on the continent. And this is just, I think, from yesterday or the day before yesterday, the arrival of a mRNA, the beginnings of an mRNA manufacturing solution to scale up vaccine production on this continent. And again, I hope I have learned to bet on the commitment of the Rwandans to health equity, which is why I'm sitting here today. Next slide, and last slide, at the University of Global Health Equity. This is the hospital that I mentioned, built a dozen years ago, but now the third-year medical students have begun their rotations in the hospital. And I hope this image leaves you with some of the hope that I feel in part from working in places where who lives and who dies is always determined, or too often determined, by their social station, by racism, by histories of colonial rule, by gender inequality, and that this can be countered and has been and will be when we come together to build a progressive social justice movement that reaches far from wherever we may live. Thank you very much for having me back.
Thank you, Dr. Farmer, for your remarks. I would like to now introduce our discussant today, Dr. Kalamaoka'aina Niheu, who also gave the Oli to open our evening. She is a Kanaka Maoli family physician, and until just recently, the Associate Medical Director for COVID response at Lifelong Medical Care. She is the co-founder of the Standing Rock Healers Council and the Mauna Medic Healers Hui, and physician for Onipa'a na Hui Kalo, a Hawaii-wide coalition for the revitalization of native Hawaiian traditional Kalo farming and food sovereignty. Over to you, Dr. Niheu.
Lahaina, thank you so much. That's always a hard act to follow with all of the history that Dr. Farmer provided for us, but also something that's important to follow through with. For us as Kanaka Maoli, we historically have looked at the mo'okuauhau of our people and the genealogy of our peoples, honoring our ancestors and all those who came before, not just because they're ancestors, but because they're also people who had laid down the pathway on which we will walk. And we in turn must then become the ancestors, the good ancestors, ideally, that will lay down the pathway for our children and their children to come to lay down. And I believe that both social movements as well as healing and medicine also have a mo'okuauhau or genealogy. And so providing this genealogy, really Dr. Farmer really opened up a lot of the discussion globally about what can and cannot be done. And like he had mentioned earlier, when we talk about health and we talk about health equity, we often are talking about what we often talk about and focus on what is and is not possible. And a lot of times we focus a lot on the things that we can't do. And I think that as far as any healer is out there, any physician, any provider, any nurse, any community health practitioner or social worker, the thing that breaks your heart is really the things when we are told that we cannot do. And I think that one of the things I always love about Dr. Farmer's work is that he always is fearless about saying, you know what, why can't we do this? What is stopping us from actually shooting for something that is greater and more humane and more just, not just here, but for others around the world? And so putting it within the context of Hawaii. And one of the things that struck me, and as I actually put a question in there that he actually addressed during his presentation, was what's the copay that folks are paying at these hospitals in Rwanda? And one of the things that he brought up was one of the first things that they did was to get rid of very punitive medical bills. In the United States and Hawaii in particular, you see supposedly heartwarming stories of a 10-year-old who creates a GoFundMe for his mother dying from cancer, health illness, HIV. People paint that as something that is considered to be a heartwarming tale, when in actuality, it's a horrible story. It's a terrible thing that a 10-year-old has to go and ask other people who are also suffering to try and pay for their mother, when as a child, they shouldn't be having to worry about that kind of situation. The success of the vaccination program and the HIV treatment that you see in places like Rwanda is in large part because the doors were thrown wide open. Baking in the message of equity is essential to reaching all equally. The big reason why I decided to take on the role of the COVID Associate Medical Director of COVID Providers at Lifelong is because I knew at that time, because of the own history of our own people, was that when it came to infectious diseases, our people weren't genetically predisposed to suffering more from infectious diseases, but the vulnerable, the poor, the more marginalized are always going to be the ones that pay the most. And because of that, I wanted to step up to take care of not just my own peoples, but my Indigenous allies throughout the world, as well as to be an ally to the Black folks, both in my community and beyond, who are also experiencing the same type of worry and concern about, will they be experimented on? Will they be treated like human beings? Or will they be discarded or utilized as guinea pigs? And these stories they talk about with the Tuskegee syphilis study, by focusing only on that, something that happened many decades ago, it invalidates and it gaslights basically the fact that at this point, at this day, there are still involuntary surgeries occurring in incarceration sites. There's still sexual abuse cases that are happening in communities by healthcare professionals today, particularly in vulnerable communities. And it obscures the fact that why are we having in the wealthiest country in the world, how is a country like Rwanda providing more excellent and equitable access to healthcare than places like Hawaii or California? So there is a vaccine apartheid that is happening globally, and we have to respect the fact that that's happening, and that's happening today. And that's part of the suspicion that, they might not be implanting a microchip inside of you with these vaccines, but they're certainly making money off of our suffering and our ill health. So when we look at these situations, particularly now moving next into these oral medications, Paxlovid, Molnupiravir, Evusheld, how accessible will people be able to get these types of medications? And part of the reason why people aren't willing to get vaccines is because we've really yielded the field about having that accompaniment in our communities. That for decades, I've been trying to fight in our communities the misinformation about vaccines, but we were asking them to come to our spaces, to come to our ivory towers, to humble themselves and subjugate themselves to potentially putting their family under deep and crippling poverty in order to even get basic advice, to even be aware that these resources are then available to our communities. So here we are finally in this space where we're understanding that if not everyone gets treated, pandemics happen, pandemics are prolonged, and deaths increase. And it's not just with COVID. We need to start looking at how they're looking at things in Rwanda. We should be inspired by the role of the healthcare workers there. We should have healthcare workers going house to house into the community. We should have universal healthcare. We should have a health system that is worthy of trust. How can people look at leaders in our government and see them saying that you can trust us on one hand, and then still having the same people, who we've been telling for decades that the Red Hill fuel tank is leaking into our aquifer system, endangering the water for all of our generations to come on the island of Oahu. We've been saying for decades that this is a real issue, that the heavy military presence really often does not provide our people the voice. Why aren't they providing the support in health systems when they are creating such damage ecologically to our ecosystems? Why aren't they helping participate and supporting the health care and wellness of our people? And why would we expect our people to believe those same voices when they say, trust us, take this medicine, inject this into your arm? But I still think with all of you here, there's enough of us here to believe that this is very possible. It's very possible because right now, 50% of all healthcare dollars in the United States simply goes to figure out who pays. And ultimately, the people that pay are the people of our community. And now with situations like a pandemic, all of us will pay. All of us are alone and lonely. And now is the time to envision and dream of a time when we are united together and healed and whole. Mahalo nui.
Thank you, Dr. Niheu. We have a question from the audience. This one, I believe, is directed to Dr. Farmer. Let's see here. Jan Brunson, anthropology professor at UH Manoa, asks, how do you reconcile signing a statement of support for a colleague accused of sexual harassment with the values of social justice? When you signed that letter of support, did you not realize you'd send a clear message to graduate students that it is not safe to come forward with such information against powerful people? Do you intend to address with a public statement the uproar in the academic community that followed news of your support of a colleague accused of sexual harassment, and moreover, to reassure graduate students that their complaints of sexual harassment will be taken seriously?
Well, first of all, I want to say that I don't think that I can reconcile that. I think it was an error, and so I agree with Dr. Brunson, and I think saying that it may well, and publicly as I have, may well be. To me, it feels insufficient. I said that as well. And I don't really, unless I wouldn't want to sound like I was defending myself by saying that the topic at hand was about graduate student advising and a request for transparency in the process. But I'm particularly saddened and again and apologetic because what I later learned, by which time I had removed, as had I think most of our other colleagues, their names from that letter, that one of the women involved in the suit is someone who I respect greatly and have taught with, and so in fact I agree with the critique. I don't feel that those two things can be reconciled, and so I think it's better just to say I made a mistake and I'm very sorry about it.
Thank you. Next question is from Ann Wright, a former officer in the military who is an activist against the excesses of the military here in Hawaii. She asks, with all the violence in Haiti, is the hospital you helped establish still able to function?
Well, first of all, there are 12 hospitals, and because Partners in Health is built the way it is, I'm happy to tell you the answer is yes. There are over 7,000 people working in in Partners in Health in Haiti, and they're really all Haitians, right? And so, although we've had many problems, the same ones that you've read about, kidnapping, the events that followed the assassination of the president last summer, the earthquake. In spite of that, my Haitian colleagues are running what is probably the largest trauma center in the country, the largest site of training of subspecialty nurses and physicians. The numbers that I can see online, because they have an electronic medical register, suggest that they're seeing thousands of people a day. Again, many of them critically ill and injured. We're also, I say we, because I'm so proud to have been involved with them for so long, the National Referral Center for the treatment of COVID. So we're receiving patients from all over the country, most of them critically ill, because we're one of the few places that can intubate patients and has an ICU. Again, this is related to that same sort of dismissive, what in anthropology you might call socialization for scarcity on behalf of other people, and again, that usually Black and brown people, where it can't be done. You can't have ventilatory support. You can't have an ICU in a place like rural Haiti. My Haitian colleagues have proven this untrue again and again. And if there's one team at Partners in Health that I'm proud of most, it's our Haitian colleagues. They show up for work every day, and again, we've had a lot of losses. But I would also note that when you're not involved in a post-colonial control over care model and clearly committed to caregiving, as we just heard in the Hawaii example, you tend to be protected by the communities that surround you. And so, the hospitals are also strongly supported by the communities they serve, and are open and functioning, and indeed growing. Yesterday, for example, in Mirebalais, which is in central Haiti, not far from that place I showed you, we're trading telepathology results with Rwanda. So we can actually, and Haiti has more clinical capacity than we do here. And I would just add, for the person who asked the question about Haitian deportees, we're pretty lucky in the United States if we can say that 15% of Black doctors in the United States are Haitian. Many of our leaders in Haiti have been working in New York or France or somewhere else, and they came back to serve in Haiti when they had the adequate staff, space, systems, and support.
Thank you. This question from a viewer who is a resident of Waipahu on Oahu here. He or she asks, what can we learn from your efforts to improve and expand care in the world's poorest places that can be applied to places like Hawaii? Perhaps Dr. Farmer, you could try that, and maybe Kalama could chime in too.
I didn't mean to interrupt. Let Kalama go first. Sorry, I'm getting excited by the question. That's all.
Well, I think that the fact that I think that it's really a healthcare system that is. We need to have healthcare systems that's very from the ground up, that people are very much involved with. I feel Hawaii is identified as having a kind of a universal healthcare system because of our Quest healthcare system. And I think that that's something that's a bit of a misnomer. I think it provides a lot of social safety net, but currently your healthcare is still very much tied to your employment. And your employment is, there is a class structure towards healthcare that exists in Hawaii that we really need to abolish. We need to have a healthcare system that everybody has access to, and we're not afraid of accessing it. And I think that that's something that these right now, just because we have Quest, and I think it's very robust. It's much more powerful than they have in other states in the United States. However, I think it needs to be a lot stronger. I think we have to feel outraged that there are people who have one type of health insurance and can only access certain places in supposedly a civilized state. But we feel like they are they aren't worthy of getting excellent care just because they're poorer. That if you don't behave and don't have a good job, that you should be happy with less.
I just want to add, Massachusetts is one of the wealthiest states in the nation. It also could hardly be described as a medical desert, although I do believe we should reconsider that given the weakness of the public health investments. But my colleagues at Partners in Health and Harvard, and the teaching hospitals, my day job, as opposed to volunteer work, were invited by the governor of Massachusetts to help lead the contact tracing program early in the pandemic. Now, we always knew that we would want it to be an accompaniment program, along the lines of the work that Kalo has been doing, and not just on COVID. We always knew that. That was how the trainings went. And I did not play a role in this except as a cheerleader, and got to meet people and learn from them. But we also found out something that I found shocking. If that fifth S, staff, stuff, space, systems, the fifth S is support. The message that we were trying to give is this is not control over care. Trying to surveil. It's trying to protect families and help them get through this. What is it that you need? I'm not sure of the numbers, but I'm pretty sure that 100,000 people were involved in an informal study. And, that's a lot of people who did say, yes, we do need help. And 80% of those families, their number one problem was food insecurity in Massachusetts. So yes, there were problems with rent. Yes, there were problems with the lack of, especially, as Kalo says, especially the unevenness of insurance programs, even in a place where, there's, mandatory health insurance, one of their first states to have that. There were those problems. And then, as everyone knows, a lot of patients who needed care for other problems other than COVID, and I'm particularly thinking about mental illness, diabetes, malignancy, that whole long list of the kind of problems that you both face, address in your clinical practice, did not receive that care. And if I could I know I'm bragging about Rwanda, but during COVID, where there was an extreme lockdown, one of the biggest questions for my colleagues across the way here was, what do we do about our cancer patients? In fact, many of them come from other countries, neighboring countries, Burundi. I can see Uganda from here, right? Tanzania. And again, why would they come from countries like Tanzania, which is wealthier than Rwanda, probably, certainly Kenya is again, the user fees and the roadblocks. So there was a great concern among my colleagues here about what are we going to do to make sure we get either chemo to the patients or the patients who need IV chemo here or in other countries. And I can't help but say it. Within 48 hours of contacting a drone company, when I hear drone, I think bad things. We were delivering oral chemotherapies to patients right near their homes. That's here in Rwanda. And that still goes on today. Usually at night, when I see a drone, it's delivering blood, right? But it can also deliver medications as well. When an effort to get medications to neighboring Burundi, a diplomatic effort, and this is, my colleagues, not diplomats, trying to work through ministers of health. When that didn't work, they kept at it and worked with a Cancer Survivor Association or Cancer Sufferer Association in the capital of Burundi and used DHL to get medications there. During the lockdown, all of the vehicles in the fleet, ambulances, Jeeps were reassigned to find these patients, and Partners in Health had, laissez-passer. We could travel. The police supported it. We even worked with the military hospital to move one of our cancer treatment centers into the capital city there in the military hospital. So I'm just saying that kind of can-do attitude is what Kala and I are both calling for, saying, is this going to be the house of yes or the house of no? And I know we could have done better. Obviously, we did uniquely poorly as a nation, the United States, and that's why we lost friends, family, and patients. But again, I hope we can take heart with some of these examples.
Thank you, Dr. Farmer. We have lots of other questions, but unfortunately, I think we're out of time here. I know you have another commitment in a couple of minutes. But Dr. Niheu, would you like to make any final comments?
Sure, is my mic on? There you go. Yes, I think that one of the things that we need to, understand is that the pandemic has made us realize that when we have vulnerabilities, we all suffer, that people thought that, everybody's in the same boat, but then some people have yachts and some people have fishing ferries. And so, I think that it's not just about being in that boat, that we're in like a river together. And if we're working together, there's detritus and debris, and there's rocky areas that if we just worry about our own little ship, we're going to have problems. And so if we can learn from each other and be inspired by each other, but most importantly, act, create systems of health, create systems of access, and not stop ourselves to thinking that this is not possible, to actually be like, hey, what's not possible is us to live without equity, without justice, and without connection globally to each other, and to recognize the humanity in all of us.
Thank you, Dr. Niheu. So I'm going to go over some acknowledgements, but Dr. Niheu and Dr. Farmer, please feel free to turn your cameras off and mute. Thank you. So the Better Tomorrow Speaker Series is a joint venture of the Hawaii Community Foundation, Kamehameha Schools, and the University of Hawaii at Manoa. The lead sponsors of this evening's event is the John A. Burns School of Medicine's Office of Global Health and International Medicine, with support from the Noguchi Medical Research Institute. Co-sponsors of this event and the series include the Myron B. Thompson School of Social Work, Office of Public Health Studies, and the Queen's Health System. Thank you to all for joining us this evening, and have a good evening. Take care now.